I think I'll be sharing my screen. Can you see myself here?
So Hudson, can you allow me to share the screen, and then I'll introduce you, and then you can start. So we have with us. Welcome to the. I call this as a Vit Retina Master. So welcome to this video teaching. So I'm going to share my screen.
So you are the co-host now, and I will make Asha also co-host and Asta as well.
Okay.
So everybody here co-host.
So
you need to click on this desktop, sir.
Now we're going to be able to share your screen.
Yes. Okay.
We're starting to see it, but it's going on.
Oh yes. So you can see the screen.
Yeah.
Okay. So welcome to the Vit Retina Master YouTube channel, and that's what we have inaugurated now. Thanks to Dr. Aishwarya, who's made the YouTube ready with me, and my colleague Mr. Oli, who's a senior optometrist, who's not here today, but he helped me yesterday. We created this YouTube, and this is my dream, long-term dream for teaching, and that's how me and Hudson are working together. So Hudson has already made another YouTube channel called Retina Awesome for the practicing vitreoretinal surgeon, and I've taken a cue from that, and then clue from that, and started this. So we are just starting the inaugural meeting today. So we stay tuned to the Vitreoretinal Master YouTube channel, but we are streaming this live from the through the sorry. Okay, so anyhow, we are doing the YouTube channel. So this channel is to teach vitreous and retina surgery to residents, fellows, young ophthalmologists, and all ophthalmologists interested to learn. And what we want to teach is me and at present the teachers are Hudson, but we have our consultants, Dr. I'll just let you know. So we want to teach the basic in vitreoretinal surgery, surgical videos demonstrating the skills involved in vitreous surgery, lectures on topics related to vitreoretinal surgery, recent advances and newer techniques of VR surgery. So this is our inaugural lecture series, and thanks to Hudson for putting this up. So main idea is we wanted to, during the COVID time, there are not much of patients, but at the same time, we want to keep continuing the clinical education to our ophthalmologists, or either who just joined residency, who don't know what to do, or they have a COVID posting. So this is a resident class where vitreoretinal surgery teaching through an innovative way of learning surgical basics for postgraduates and fellows. So today's topic is scleral buckling, when to do and when not to do. And we have none other than Dr. Hudson Nakamura. And we have panelists, our consultants from Aditya Jyot, Dr. Jaydeep, Dr. Asta Jain, Dr. Amit Jain. And we have Dr. Aishwarya Rai as the fellow. So I'm happy to introduce Dr. Hudson Nakamura. He's a medical specialist in ophthalmology and specialized in retina and vitreous. He did a fellowship in vitreoretinal diseases in Toronto, Canada at the University of Toronto, and another retinal fellowship in his hometown city, Goiânia, in Brazil at the CBCO Brazilian Center for Eye Surgery. He completed a study from School of Medicine at the Federal University of Goiás, UFG, Brazil, and residency from the base hospital of the Federal District Brasilia, DF Brazil. Former attachments as member of the American Academy of Ophthalmology, Brazilian Council of Ophthalmology, Canadian Society of Ophthalmology, and also ARVO, the Association for Research in Vision and Ophthalmology, US. He is currently working as professor in Department of Retina and Vitreous course of medical residency in ophthalmology and fellowship in vitreoretinal diseases. He is also founded together with myself as well as others of the Retina Awesome, which joins the retina specialists from different countries. It is 100% totally Hudson's idea, which he has done, and we are coming with the next one is on September 12th for the practicing vitreoretinal surgeons to interact and present interesting cases in vitreoretinal surgery. He has done 4 successful retinas. So today, as I said, we have Dr. Hudson Nakamura, and I think, according to me, he's a dynamite and a young, energetic professor who is willing to teach. And I'm glad that finally I realized my dream of teaching. Because in between last 5 months, even though we conducted several webinars, that's all for practicing doctors. I think we did some motivational talks for young undergraduates and postgraduates, but today is the day we have started teaching, and we wish more and more speakers will be there. Already Hudson has made a schedule every Tuesday, say at 15:30, 3:30 Indian time, and so we have the YouTube live and Facebook live, and then stay tuned. So I'm stopping my screen, and over to you, Hudson. You can take over.
Sure. So it's always a pleasure to be here, and we are going to be learning together. And thanks for the introduction. Can you see my screen over there? And I will. Can you see it?
Yes.
So I guess the screen is large enough. I'm trying to get the actually a little smaller. Just a second. Let me go to PowerPoint over here. Let me share. Not there. Let me share through here. I think it's better. Yeah, you can actually see the screen. That is the internet. Just a second. These internet things are teaching us a lot, no?
Yes.
we learn every day. The image was so cool that I thought it was the PowerPoint, but it was actually the internet. So I will move it down here. We have the keynote over there. Let's share again. I got it. So just a second. Play slideshow. Okay. I guess now you see my screen, no?
Yes.
Is there anything on the screen besides?
No, it's fine.
No, everything's fine. Okay. So we have our residency program here, and the thing is, we try to relate to each other more than we teach. Of course, we teach. We like teaching, but it's very important to relate because we are going to be together with our residents and fellows through the time. So we prefer to show how things work and how we could relate and make the best from our teachings. And I'm going to ask probably Asta that I made this co-host as well. If anybody gets in, you just admit them, okay, Asta? And so we are at the iBank Foundation, and I'm going to talk about scleral buckle, doing scleral buckle or not for retinal detachments, in vitro retinal surgery as well, and scleral buckling surgeries alone, and why we are doing that and why we should do and not do. So I presented these several times so far, but this was a meeting in 2015 in Baltimore, and we were talking about the advantages of combining surgery, the scleral buckling surgery, together with vitrectomy. But the thing is, should we be doing the surgery alone? What the indications are for the scleral buckle? Whenever you want to do the scleral buckle, if you want to do the scleral buckle alone, or if you want to do with vitrectomy. But what are indications? What the indications are for the surgery? And Natarajan knows these times because many years ago, we used to perform scleral buckling surgeries with a lot more indications than we do now. But because we got to the 20, 25, and 27 gauge era, people kind of forgot to do scleral buckles, and so people prefer to go ahead and do a vitrectomy because it's easier, saves more time, and you don't have to work that much for the scleral buckle to open up and to put the band and do things. And even some services and even some people, some doctors, they counterindicate the procedure and they go straight ahead to the vitrectomy. But we cannot forget the history inside this all. So there are old things from the past, but we still keep them working. And why we still keep them working? Some of them are still hard, good, and they last, like this machine, still working. And in the past, as you see here, we did not have too much and good materials to work and do surgeries and even see the patient. So it was very difficult to record. This is fundus photography, and also this machine was able to record not anything close to what we have today, but that was a start. And today we are able, with new equipment, to see the peripheral retina, to see the retina with good stuff, good lenses, good condensing lenses. So we go up to the periphery to see all structures. And this was a paper we did in the past comparing scleral buckle and scleral buckle vitrectomy for pseudophakic and aphakic retinal detachments. This is a good indication for that. But even today, I do scleral buckle combined with vitrectomy for phakic patients as well. But when to indicate, that's the thing. This is what we had in the past. You see, we have a lot more today, more options. What we like using today, mostly is the 240 band and the 42 band, the buckle 276 tire. So we have a lot more options than we had in the past. This is a book from 1965, already showing details on the surgeries, showing many materials. And if we compare to today's time, we have a lot more options, of course. But still, even though we have so many options in today's time, people don't want to do as much buckles as we could do because of the modernity. And as I said, even some doctors, they do not indicate the procedure due to personal reasons. And I gotta tell you, in the past, Natarajan, I had a loop that I used for my buckles, but because presbyopia ensued, now I use the microscope. I see a lot better with my microscope. I see the details. I see whether we have vortex veins. I see the sclera thinnings, and we can zoom it in, zoom it out. So it's a lot better today. And basic knowledge from this buckle, for example, 276, we have the buckle measuring 7, but we gotta give the stitch a little more, 9 or 10 millimeters to get it steeper and a good indentation. And on the top, you see 2.5 millimeters, the space you use for the 240 band.
Excellent.
As you see here.
No, you mentioned about using loop. I have seen my mentor using the loop in 1984 when I did my fellowship. And that time I was telling him, you have a microscope, you are doing vitrectomy, and why do you want to use the loop for you doing the scleral buckling? So I actually started using the scleral because my passion was to do microsurgery. That's how I landed up in vitrectomy surgery in 84. And I convinced him because he was doing vitrectomy with microscope, and he'll do buckling without microscope. He'll move the microscope away and then do the Charles Skipham's implant, because he was a fellow of Skipham's and he was doing for every patient an implant, sometimes 360-degree dissection, and then you use the loop. So I told him, why can't we do the, because he said it's external surgery. I said, so what? So then I remember the squint surgeon took over for even squint surgery. He used to say, oh, I can see better. But I think it's a world of difference when you use the microscope. Then I found out in the late 60s, I think there was some publication, few people used microscope, and I know now everybody only uses microscope, which is, I think, important because apart from using indirect, I think scleral buckling, you should use the microscope so that you identify the vertex veins and also the tissue cap. Because when I remember in 84 when we were operating, turning the eye this way, that way and the eye, next day you can't open the eye. And that's because you're pushing and pulling the eye too much. And now with the microscope, your movements are restricted and probably microfined, which I think the tissue care is better, so that the next day the eye does not look like you're operating. Go ahead. I hope I can add some
still
points.
I think the same story. I started using the microscope. We see a lot better, but I like to show off my loop because this is something to remember. This is so good, and it's a hassle. You have to remove it from your eyes and go back to the microscope, and so why don't you go straight to the microscope? You see better. You just have to find your way and move the eye. Maybe you have to tilt the head from the patient sideways and to find the place of the suture. But scleral buckling surgery takes some engineering, it takes some thought and lots of patience, and not everybody today have that patience. And
Yes.
so that's why so many
I'm
go ahead
glad
and
you
do
took this topic.
vitrectomy.
We have Amit Jain, Asta Jain, and also Jaydeep, all I think a similar school of thought and training. They are doing independent surgeries and they are consultants. So I think we can make it interactive in between. You can ask us questions of sometimes, so that for the audience and for the students it will be interacting. And I'll also ask Aishwarya, because this is your first class. You can definitely ask your doubt, because I'm addressing you as a student, but there are a lot of students world over. Maybe we are not having them directly on the Zoom, which we have to make a mechanism in future. So maybe in between, each one can either raise your hand by this way, or putting in the what do you call the reactions which you have. You can even raise the hand, right? Hudson,
Of course,
you
of
don't
course.
mind, or you can also ask a leading question to them, so they can also add their points.
Yeah, and now, it's up to you if you want to speak. And I gave them the co-host, so that's not a problem. So we are here to discuss. And as we have these drawings here, the buckle
Hello?
cannot be too tight, cannot be too loose. It just have to be the right way. So you have the buckle from the C is too tight. The one from the letter B is okay, and the one from letter A is kind of loose. So these things have to be thought about. And if you are combining the surgery with vitrectomy, the buccal with vitrectomy, oftentimes you don't need to be so hard on the buccal to get a very high-end indentation. But then I will tell you the advantage of doing more or less indentation.
Hello?
And we have here a book from Charles Skipham's. I like to show these things, Antarajan, because people do things today, but they don't know what they came from. So it's good to explain and show the some history. So this book from 1965 from Charles Skipham's and Reagan, showing from the Retinal Foundation, Boston, you see here actually the top left figure. You see that the buckle started with the resection. We started with the sutures, and then resection over the break. They put a partial tube instead of the silicone materials we have today, and then a circling tube with a silicone implant, and then we come up with the materials from today. There is the silicone bands, and the 240 bands, 76 and 42, and all others, and
fantastic!
Different materials that we have. And this is interesting to read. It's a comment from
I think we have to make it
Dr.
revamped.
Skeppins. Because today we are deciding whether to do buckle or not to do buckle, or to go ahead and do tractally. But in the past, there were discussions and two-step operation for retinal detachment. And you guess what? They were thinking, should I be doing the buckle completely, or should I be doing the part of the buckle, and then in the other sitting I will do another buckle. So it's interesting to read this, because Charles Skeppins commented on that, saying that the best thing would be, he took his comment here up above, is to do the
so they don't have to
buckle completely, and not to do partial buckle and then the other half of the surgery, because they thought by doing just the drainage, they doing just the first part, and then approaching the RPE from the sensorial retina. They could do the second part later in another sitting after the inflammation was over. So, but this thing came up with too much PVR and applications. And I want to read something here from Dr. Skippins, because this is history. I'm less optimistic than some of the speakers about the post-operative settling of a retina when a buckle has been obtained, but the retina is not reattached at the end of the operation. It has long been known that if a break is closed with simple diatemy alone, a pocket of fluid may absorb post-operative. In my experience, however, this does not happen in so-called unfavorable cases with much vitreous traction. This is one reason why I am not enthusiastic over the two-step method, since the conjunctiva and tetanus capsule already open. The surgeon has a opportunity to release subretinal fluid, thus completing the operation in one step. This is the thing, And so even today, whether we decide 2020 to do buckle or vitrectomy, in 1965 they decided whether to do partial buckle or completely buckle. And this is just an example. And as I said, the same figure I showed you 5 minutes ago, showing whether you do more constriction from the buckle or less constriction of the buckle, you see here in the same book. So this has not been changed. What changed is whatever we do for more or less. But you see the same figures, whether the constriction is excessive or not, and or to lose. So this is a nice picture. And we have this updated picture here, and we know that the buckle should sit on the break and do a perfect indentation. Otherwise, the retina might not be attached, and you might get out of the pressure of the buckle, of the tightening of the buckle. You might get some other complications. So you gotta put the buckle on the hole or holes. And if you have them in the same lining, this is good. But you don't have them. If you don't have them in the same lining, you gotta put a rail band and the complete the buckle by doing more steps of surgery. And that takes longer. So that's why not very many people are interested in teaching or even doing that. This is a picture from Mayo Foundation, and here, interesting result from a very high myopia patient. You see the very good indentation, and actually, when you do vitrectomies today for very high myopes, and the eye is quite large, I wouldn't do such a indentation like that for the surgery. It's probably too much, but the outcome is good because the sclera is thinner, and therefore very high myope patients we are allowed to do that. And we have here today the silicone band, for example, and the silicone fixation sleeve to put and tighten the buccal. But in the past, we did not have those things. We had these tantalum clips. You see, Natarajan, we did not have the silicone fixation sleeve. Now we have sutures, we have Mercilin, we have Dacron, we have even some people in the past, that very not long, used nylon, but I think nylon is not very good for the eye, even though you can cover with a conj. But today, in the past, they used this tantalum clip, so to hold the band in place. We don't need to do that today.
No, Skipens also has described a brother's knot, like a double thing in the suture, which you can use instead of the tantalum clip, and which Dr. Skipens has described in his big voluminous retinal detachment book.
Yes, and then this big suture might get some indentation as well, and hide the band of the buccal inside. So things are favorable for us with time, but it's good to watch these historical pictures, and so it gives too much of work to do that. But it's still, if we had this and we had to use it, we will probably have a successful retinal detachment surgery, scleral buckling. And as you have here, drawings are very important. You have the thin line and the thin black line. You have the 240 band, that is, which is called the encircling element. We have the buccal supratemporally there, and the buccal is where the break in the retinal detachment was. Even though you have a large retinal detachment, but you have one break supratemporally, but still the patient was elective for the scleral buckling surgery. You don't actually need to do vitrectomy. If it's indicated a buccal, you put a buccal there and drain, and then you have the right positions and do whatever you have to do to close the hole, either cryotherapy or laser. I prefer today to do laser because after you drain, you have the RPE and the neurosensorial retina opposed, so you actually, the laser takes better. But if you don't have, and the fluid is too much, but still you want to close the break, you might use the cryo as well. But the thing today is not to use the cryo so much, because it could cause more inflammation and PVR and things. But cryo is still a very, very good treatment. And it was reading up into this book, Natarajan. They are saying that, we have good pictures. I'm not displaying here for the sake of time, because there are so many pictures and good pictures to see. The surgery is actually with cryo as the only therapy, like doing the buccal, not doing the buccal, only doing cryo for everything. So quite a few cases
but
that work.
Time is not Hudson. I think the idea is teaching students. So I think probably we have to make a mechanism of asking questions from the students. But I hope Aishwarya will ask now, or maybe Asta and Amit and Jaydeep can add it. But I think whatever you have, I think this is the time. It's not any time constrained session. But I agree. You also have to start your work. But you can show all the pictures, and you can even divide the talk. Maybe if we can't finish today, we can continue and then postpone the second topic a week later, so that we have a lot of learning. And I think I'm really amazed, and I'm happy to see your old pictures, Charles Kippens and Mayor Shrikrath. Really great, because I was a second mentor with Relja Jonas, and he always told me it's very important to know history. And I always remembered from my school teacher, the history I remember as high story. And the reason is, I think Isaac Newton also has mentioned, you don't have to reinvent the wheel. And I think if you are able to stall on the already the tall stalwarts in the field, you can see better and you can probably learn better. And that's the idea. I'm creating a platform
Yeah.
where first student will be. Maybe Amit, you like to add something? Amit?
Yes, sir.
So Amit is also trained in my same alma mater. Yes, Amit.
Hello, sir. Yeah, so scleral buckling, as everybody knows that it is now art which is not practiced with me. However, my mentor was Dr. Mona and she taught the buckle. Uh, Buckling for me is any detachment. The first most important thing is you should be able to indent and see each and every area of the retina. That is the most important. So there's no shortcut to it. You have to indent, depress, and see the retina through indirect ophthalmoscopy. Only then you can decide for buckle or not. You cannot miss a break. That is the foremost thing. And second is, if any break is depressible, it can be buckled. That is my first. Whenever I see a RD, if it is the break is depressible, then my first option comes as a buckle. Only if there are other factors which limit the procedure as buckle, then I think of a vitrectomy with or without Amsler.
Yeah, you are right. And for me too. But because we did that paper and we saw so many patients in Toronto, Canada, where patients after cataract surgery, especially pseudophakic, but some aphakic, but usually those patients, they have these very tiny, small little breaks in their very retinal periphery. So some of them deserve a combined surgery, because oftentimes you go ahead and do a buccal, but you might not see a very small break elsewhere, and the surgery may fail. And by doing the vitrectomy altogether with the scleral buckling surgery, you remove the RPE cells, you clean up the vitreous, you have the more mobile retina, you get away with tractions and doing the two things, and having the benefit of doing the buccal with the good indentation, you can do a very good surgery. But I still with you in the thought, and still doing the buckles whenever we can do, and not giving up on them. And this is this book from is still updated from
Alice McPherson.
1968, yeah, long time ago, from Alice McPherson. You see here, they are showing good things from
So
the buckle.
I knew Alice
After
McPherson
you do,
well.
Yeah.
Because of the
right place to do drainage. You see the right place. If you go in the image from above, if you drain near the hole or the break, you might get the retina trapped. So if you squirt away the subretinal fluid from the detached area and towards the break, and towards away from the break and towards your drainage site, the retina gets attached with no subretinal fluid, no fluid inside the vitreous, and no retinal trapping. So this is a good picture. This is updated from today. And as you see, some techniques did in the past, they trained away from the buckling procedure, as you see here. But today, in today's surgeries, as Amit Jain, I think he does that as well. We do the drainage below the buccal, then we cover it, but not close to the hole. Isn't that, Amit?
So I have been seeing a few cases. So from last 3 years, I am doing almost 90 to 95% of my cases non-drainage when it comes to buccal. And I do believe in the process that drainage is just for our satisfaction. Many a times, there are cases where there would be a very thick RF and drainage would help in the process to retina to flatten faster. But then drainage is only for our peaceful night sleep. Whereas many a times if you just oppose the break to the buckle and do your adhesion of the cryo or laser, whatever, in next 1 or 2 days, you will see all the SRF being drained out by the RPE pump mechanism, and drainage you don't need. So by avoiding drainage, I avoid all the complications associated with buccal. Mostly they are associated with drainage, like suprachoroidal heme or subretinal hemorrhage or retinal incarceration. So I prefer to go completely extraocular, don't go intraocular at all, except for paracentesis, just to lower the IOP when I give a tightening of the buccal.
Yeah, that's what I was going to tell you. If I had to do the surgery without draining, it's okay. If you have a shallow retinal detachment with not too much fluid, you can do that, no problem at all. But I would do at least an anterior paracentesis, because you might need to tighten the band a little bit, and so the RPE pump, as we say, is going to work through the night, so you don't need to lose your good night, a good sleep. And then if you did the laser, and it's okay, I think it's okay. But the thing is that the reason I like doing drainage is that, especially in those huge and deep retinal detachments with too much fluid, when I do the drainage, the laser, because I'm doing more laser now than cryo. If I had to do only cryo, that would be okay, because I do the indentation, so I freeze the hole or the break, and so that's okay. But because I'm doing more laser, actually most of my cases I do with laser, even though if you have a round hole and it stays seated after the drainage on the buccal, you might not need to do even laser or cryo. But because I'm doing laser, I drain, and then, well, of course, my drainage is very careful, because I do pretty much like they are doing on the picture there, but except for the stitch, because I put the buccal on the drainage sides, but I don't need to stitch it. But then I be extra careful not to cause any hemorrhage and things. As you said, you have to see the choroid, and you have to open up and withdraw the sclera to see the bluish thing there, and then you do the right step. And then after doing the drainage, I do the laser. So because now the RPE is opposed to the neurosensory retina, so it's good to do the laser. But yeah, it saves time. Also, we gotta be extra careful to find those vessels. This image is so interesting. It was drawn, but you cannot go too posterior, otherwise you might get vessels there. And it's a good way, transillumination, to see whether your break, your vessels are, in this case, they're showing vessels and nerves. You can see through the transillumination. And there's was showing the tantalum clips that we don't use anymore, but still ways to move the 240 band or any other band up or down. You have a broader band like a 42 for a larger break would be okay. I had a professor, Dr. Berger, in Toronto. All his buckles he used a bit. All his buckles he used the 240 band. It's too thin, but he used 240 band. He put the 240 band over the break there, and he would tighten a little more. He would even do more sutures, just more spaced. So you would create more indentation, but he could get away with cases by only doing the 240 band. That was awesome, and he was very good at doing that. Diathermy, opening the SCLERAL that way. Some people still do, and there are some materials to do that. I actually personally, if I'm extra careful to drain, I use only the tip of the needle, the very tip of the 30 gauge needle, for example, after knowing that I don't have any vessel or any other bad possibility of getting any hemorrhage, but still you can use these electrodes to go on with. These are interesting pictures. And after closing, you see the materials from years ago. This was a very good advance. Nothing compared to the ingenuity we have today, Nataraja. This is interesting to see. And this inflammation caused by the opposition of scleral buckle towards the sclera, you see that helps and helps the buckle to stay there in place. And it's good to have the indirect to see the patients. And how many of you here do indentation? I guess everybody does indentation, and I use the indirect. I look for the break always at the very retinal periphery. Some people use the 3-mirror lens, but I might use it, but I think it's a lot easier for me to see with the indirect and see the whole periphery. And how many of you guys use this? And I would like to ask, what's her name? Ashara. You like using the indirect?
Yes, sir. We use the indirect lens while examining patients. So right now, I've just recently joined my workplace, so I've not yet had the opportunity. But in my previous place, I was using indirect ophthalmoscopy, binocular examination with indentation.
Yeah, that's good. Yeah, binocular. If you get used to that, it's the best thing, And for better resolution as well, reduce distortion, and here many different materials we have today, very good ones without the cable, without. And the good thing is to draw. We did go to the OR, but before going to the OR to do a buccal, our teachers, Dr. Lam, Dr. Deveni from Canada, Dr. Marcos Avila here from Brazil, and other doctors elsewhere, Dr. Berger, Dr. Harvey, Dr. Mandelkorn, you had to draw it, but usually people today don't have time to draw anything. But it's good if you have a drawing, but today everything is electronic. You go to the computer and you see everything there written. But if you have a drawing, it is so good to teach the residents, and I urge you to draw your patients in the special charts like you have here. You have to know, I was taught to draw this way. The patient is with the head up, and then you put, you see the patient, 12 o'clock there, his head is pointing there, the arrow, and then the drawing is the other way around. You see 12 o'clock is in the opposite side. And whatever you see, you just draw. It's going to be right there because the lens is inverted, so you draw that way. You see here?
This is from the Rosenthal article. Is this from Highlights of Ophthalmology? This pictures, Hudson?
Yeah, no, I don't know. I got it some time ago, and just put it into my presentation. I think so. Yeah. I think so. I think it's from Highlights of Ophthalmology.
So tomorrow, Aishwarya is going to come to the hospital, and every fellow in our Aditya Jyot gets a printout of this 30 pages article, as well as in the fellow's manual. And every consulting room has a set of color pencils and a drawing.
Yeah. Yeah, we have to have, the thing is that nobody has the pencils anymore. They think these things are from the past, but they are not. Natarajan, that I don't know very many people that do that, but I do inverted vitrectomy. But by the time I'm there with the patient in my 12 o'clock position, and I'm facing his head from the top, and I operate the right eye, for example, I see the same right eye without inverting. So, as if I was drawing. You understand what I say?
Yes.
If I'm gonna operate the left eye and I'm on the top of his head there, I'm operating the left eye. I put the condensing contact lens there, and the image inverts. Actually the lens inverts the image. I'm seeing the left eye like that. I'm seeing the left eye. So that's if it was drawing. Understand? So.
Yes.
I trained myself with that, so I don't use inverted at all. But I won't teach that to the residents and fellows because they have to learn. It's quite tough.
Yes.
I try to teach some, but they don't. They wanna do that, and it's good to do proprioception and keep the other patient's eye open so that you can see and to better examine the patient. Use a very good indentation, and I started using the Q-tip, but it's too large and broad and make some pain. But the small clips from the office, they help a lot more. And in this way, you can see the retinal periphery, doing depression, do cryo, laser, and this is the chart. I guess this Sankara Neta, he's from India, I guess. No,
Yes,
I'm
yes.
not sure. This
That's
name
where-
is.
That's where we are trained. I myself, Amit Jain, Jaydeep, we are all trained from there. And that is founded by Dr. Badrinath, who's the earliest fellow of Charles Kippens in 1970. So he came to
Wow.
he came to India in 71 and then started getting the technology from America to India in 1971.
Ah,
And he started SCLERAL in
71.
1978.
71, I was 2 years old. Yeah, a long time ago. So by drawing, you have to see what you are drawing. These are some clues and what to look at. This is interesting, you see. And making this is just some examples. We are just going to the end. Just some examples of what you have to draw. You can draw. Actually, you have to wake this up on your mind and do very good and beautiful drawings here, as you see. I'm showing some examples. Yeah, hemorrhages, retinal breaks, and holes, and retinoschisis. You see lots of examples here. So I think it's a good thing to draw and to locate the breaks beforehand, before going to the OR. Otherwise, you might get into trouble. But it doesn't mean that I have to find all of them. But if you have a retinal detachment, you gotta find the break. Dr. Lam and Dr. Kenny usually said, you gotta find the break. It doesn't matter what, unless you have some very hazy media, but you gotta find the break and the hole. You gotta try to search for it. And these drawings are interesting that they speak for themselves. When you take them to the OR and you see just hemorrhage, you see opacity to draw in green, and if you take the drawings to the OR, that might get see the IOL inside. It's media opacity as well. It's being drawn there. You get your job easier if you have all these. So it's good if you have the article, Natarajan. Just send me the article, and I'll be loving
Yes.
to see it and read it up and spread with our residents as well.
Yes.
So different ways of drawing here, as you see, pigment epithelial detachments, nevus, choroidal detachments. So I encourage you to draw exudates, ankylosis, deposits in the RPE. So the thing is, should we be doing scleral buccal more? I think so. And I have recently, I had 2 cases recently that is from the 2 months now, when I performed this scleral buccal together with the vitrectomy. I was looking at the patient last week. We already removed his silicone oil. He was a high myopia, only eye patient. And the other eye had a surgery in another service, and the other eye doesn't actually see. And this that I operated on, he had this retinal detachment with the vitrectomy with the buccal. I was looking at his retina, and the indentation was so good, Amit, that I was so happy to have done the buccal. His eye was white, beautiful, and if you see the buccal, some doctors, they advise you, no, don't do the buccal. Today is modernity. You gotta do 23, 25, and otherwise you're gonna get the eye reddish. The eye will be too red, and these things. I don't really think that way. And when I saw the retinotomy in the very retinal periphery that I did, temporal, and I saw the retinotomy there sitting on the buccal like that. The retinotomy was flat, and the buccal was like that, 90 degrees. As you can see here in my hand, it was 90 degrees. So the retinotomy, the very retinal periphery, had the support to be there without being just hanging there without any support. We had like a wall that was the buccal indentation. In that way, the retina remained attached, and that helped with the healing and so on. So that was about it, and I wanted to share this to you because I think what is most important for you and for us is to teach and to show something, but it's better, Amit, to tell a story. You know, it's better to tell a story. Otherwise, people don't know. Okay, it's good that Hudson, he likes doing buccal. He does buccal vitrectomy, and but to tell a story, it's a lot better than just showing what you like doing. It's good to know how things started from, and why we learned, and why we do some things different today. Don't you agree?
Correct, sir. I agree, sir.
What about you, Aishwarya?
Yes,
Aishwarya. I'm still learning to pronounce her name, Aishwarya.
Sir, I have a doubt, if I may.
Yes, yes.
Sure.
Yeah, go ahead.
Sir, can you please tell me when is the right time to combine a vitrectomy and a buccal as opposed to doing just a buccal?
Yeah, the right
if you
time.
plan to do a buccal alone, when would you swoop in to do a vitrectomy, like take an on-the-table decision to do a vitrectomy when you actually plan just to do a buccal?
Yeah, usually I'm going to send you a paper on that. This is a paper we wrote back in 1998 in Toronto, Canada. But from this paper, many other papers were published with the same subject. So we kind of started this thing and these decisions. And if I want to do a buccal alone, it's a retinal detachment with no PVR, no tractons, clear vitreous, and you see the hole is usually, if the detachment is very shallow and superior, for example, 12 o'clock or 1 or 2 or 3 o'clock, it's easy. You just go ahead and do this bubble of gas, and then you wait for the resorption of the subretinal fluid. But if the break is down below, it's like an infratemporal or infranasal, but even though the buccal doesn't, I mean not the buccal, the hole, although the hole is not very large enough and does not have many tractions or no traction at all, and the vitreous is clear, as I said, it's better you do a buccal because the patient won't be sitting, staying upside down, so the gas wouldn't cover this area. But by doing the buccal, you that are indicated in this situation is that the vitreous is clear, no haziness, the hole inferior, and 1 or 2 holes close. But if you have 1 hole up, 1 hole down, no problem. You still go ahead and do the buccal. And this would be a perfect case, and especially if the patient is phakic. then I'll go ahead and do a buckle. And another thing, the vitreous in this situation, no haziness, and not very old retinal detachment, a recent retinal detachment, because the longer you wait, you might get the possibility of getting more PVR and the redetachments, and the surgery may fail. But this is my indication for the buccal alone. But for buccal vitrectomy, when I do buccal vitrectomy, yeah, okay, go ahead, Amit.
So just for the benefit of the students who are attending, when we are talking of buccal with vitrectomy, there are two things. One is segmental buccal with vitrectomy, and one is encerclage band with vitrectomy. So what you are talking would means indications for both would be different. So you can proceed, sir. I just wanted to highlight that there are two different ways of seeing buccal. One is encerclage and one is segmental.
Yeah, this I'm talking about the buckle with the whole thing, the encircling band, the 240 band, for example, and the buckle as well. I'm talking about the 240 band and 276. So I like using the circling band, so I put the buckle, the small piece of the buckle, wherever the retinal detachment is. So that's what I'm talking about. I don't usually suture only the buckle there. Could be a good idea, but in my technique, I like doing the circling band and the buckle below. And moving to the vitrectomy, the indications for the combination of buccal with vitrectomy, I do that for pseudophakic and aphakic patients. That was the subject of our papers. And by doing that, as I mentioned previously, after you do the buckle, and in this case, I wouldn't put the 276, for example, the tire, this broader buckle. I would just go ahead and either do a 240 band around the eye or the 42 band, a larger one. But usually I can get away with that with only the 240 band, as a tiny one. I put the 240 band around the eye, and then I do vitrectomy. And the combination of the buckle, I don't tighten the buckle right at the beginning of the surgery, just at the end, in order to avoid choroidals. But by putting the buckle, doing the vitrectomy, removing the vitreous with the RPE cells that could possibly cause the PVR, and cleaning up and getting the retina mobile, even opening more a break, or if it's irregular, for example, doing laser inside, using PFC, attaching the retina from inside, and then at the end of the surgery, I would attach the band. I would have indentation. I don't need that much indentation. I would have some indentation. I will have the breaks closed. And then that's the case. That's the indication for me. But if the patient already has some detachment with PVR, of course, and then I will go ahead and do the combination. Hi, JD, would like to comment?
Hi, guys. So I just wanted to ask one question. So you combined vitrectomy with a 240 band or a 40 band, 42 band, or with a tire?
The combination. Vitrectomy and the 40 band?
Yeah. Do you combine it with a tire like a 276 or a 279, or you use the band?
No. If I do vitrectomy with the buccal, my buccal would be will be the 240 band only, and I think that's enough. And then I would treat the retina from inside, if necessary. Vitrectomy, PFC, before carbon liquids, and remove the tractors around the break, or avoid any track there, and do the complete vitrectomy. And then at the end, I would tighten a little bit, and then I would get the indentation I need. So I wouldn't put, because I don't think it's necessary, because if you are doing the vitrectomy there, you already did the laser around the break or hole, doesn't matter what size it is, or if it's here or there, if already lasered the things, and if the break is round, you wouldn't not need laser. But I'm inside there, and I want to be safer, so I prefer to do the laser. and then I do the buckle in the very retinal periphery. So you shorten somehow the retina. I don't want to be too tight, so a little bit, and then the retina would stay attached. But then the issue would be if there was too much PVR or not, whether you should end the case with gas or silicone oil, and then you decide.
Right.
But I don't, as you said, as you asked, I don't put the buckle, the 276 or 277 or whatever wedged thing, and below the 240.
So, like, I think we use most of the times this 240 band for most of vitrectomy surgeries for retinal detachment. Like, I was trained at Shankanetla, and I'm sure Nataraj sir also uses the 240 band most of the times when he does a vitrectomy for RD surgery. So that is something which definitely helps, especially as you said in phakic eyes and a little bit of inferior PVR, where the PVD is difficult to induce up to the ura. In such circumstances, you would like to put this band and combine it with the vitrectomy. So
yes.
we also prefer doing that. There are certain occasions only when I use a tire like a 276 or a 279 along with it, where probably there is a large tear, especially inferior one, which is not completely supported on this 240 or 42 band. So then in that scenario, I would like to add a tire component there just to support that large tear, which is probably extending a little posterior in that scenario, because if you put a 240 or a 42, it kind of opens the posterior end of this large tear, and that is how then sometimes recurrence in PVR occurs, inferior one especially.
It is not supported.
So that scenario, I would like to put a 76 or a 279 to just a small piece with a single suture to cover that region. And otherwise, as you said, some complicated old PVR cases where phakic eyes, young patients without any PVD, especially children, sometimes it's very difficult to induce the PVD and take it up to the ura. And doing peripheral vitrectomy again is difficult. Lens touch is something which you want to avoid again. So then you can support it with a little broader buckle, probably a 276 inferiorly.
Yeah, very good ideas. And I always try to avoid the lens whenever I can. Going from
one more point regarding Dr. Amit, as he said about drainage, he prefers non-drainage, and as you said that I suppose you drain most times because you are doing laser after the drainage instead of the cryo, which I think is something we can try doing, because I don't think most of us do that. That's a great idea. What I was doing is I used to do laser to the lesions which are in the attached retina, and then do cryo to the area where there is the detachment and put the buckle. But I prefer draining somehow. I don't know. I was at Shankanetla trained by Dr. Tarun Sharma, so I saw him draining most of his cases except the ones which were very shallow, as you said, and young patients with good RP function. Then you don't want to really go in for the drainage. But otherwise, I drain. But nowadays, I'm not doing the cut down. I do a needle drainage with a 30 gauge needle or a 26 gauge needle directly through the sclera. Obviously, trying to avoid areas where you expect the vortex veins or larger vessels. So generally around the horizontal recti.
Yeah, I think it's a good idea to cut out and separate the sclera. You go there towards the sclera and you open up the area, the safe area, and then if necessary you cauterize it or not. But I think it's a good idea. And
I was
with
doing
a very
that,
tiny needle and drain it. I think it's good to drain. But if you drain, you should not tighten. Soon after you drain, you have to
I faced some
wait for the fluid to escape, and that works okay.
So
I had some experiences with suprachoroidal hemorrhages. When I was doing the cut down, I always started with that first 5 years. I was doing the cut down. So the needle I was using was the 10-0 nylon, which we have that needle for draining through the cut down after doing cautery to the base or to the knuckle of the sclera. But I found that in my hands there was a little bit more cases of suprachoroidal or subretinal hemorrhage with that technique. So
but
I
don't
tried
like
to do something
using
different.
the nylon today. No nylon, because sometimes the patient feel, even though the nylon is hidden, but sometimes if I have to suture, when I do the buccal suture, I use the Mercilin or Dacron.
No, not the suture. I was talking about the needle. You use 30 gauge needle for draining, right?
Okay. Then
So
needle.
instead of that, the tip of 10-0 nylon suture needle, that needle I was using
good idea.
draining.
Good idea. Yeah.
It's quite
It's very
thin,
tiny.
so yes, that just puncture the knuckle with that. So in Shankar Netralaya, I think this was what we were doing. I think Amit must have seen the same. So
Yeah, I
but
drain
before doing the puncture, I like to open the sclera, to
yeah.
keep this area so safe area, so that I will puncture safer. I wouldn't puncture without opening
blindly
during the slit,
Correct.
separating the edges, and then it would be a lot safer. But good ideas, very good ideas.
So I always drain. So I always drain and adjust the buckle. Amit wants to say something. I think finally you have to master finally you have to master.
Natarajan,
Yes. Yes.
You should encourage the residents and fellows to do the laser after drainage. Wait for a while until the fluid resorbs or comes out, and then you put the indirect the laser.
Yeah.
And then you do the laser around the break. It's so good, You sleep really well. Good. As Amit said, you should sleep well.
As good as vitrectomy. It is as good as a vitrectomy.
Amit wants to say something.
Yeah. Go to sleep.
Yes, Amit.
As Hudson sir told, that everything has a story, seems better. So basically, this started, my non-drainage attempt started when post-fellowship and I was out of Shankar Netralaya. In my first...
Oh, sorry.
Am I audible?
Yeah, sorry. Yeah.
Now it's okay.
As Hudson sir told, that everything, a story helps better to understand. So when I was post-fellowship, my first 4-5 cases of buccal, I tried drainage in those, and out of those 2 cases, one had subretinal hemorrhage and one had incarceration. Subsequently, I was apprehensive to do drainage for the next 2-3 cases. So I tried non-drainage technique, and it did very good. Now I have almost done more than 50 cases, and of which 48 or 49 are non-drainage. I just select my cases. I don't do each and every case as a buccal or a drainage procedure. But whichever cases I have decided to do a non-drainage, it has given a good result to me. So it takes a less time. It's like it doesn't feel also like you're doing an actual surgery, because you just go open, put an insert, and put 1 or 2 sutures of buccal, and you have to close it again. I agree, drainage makes us feel better. The second point I wanted to put was, I also do laser post-op, but I usually do on day 2, post-op day 1 or day 2, around the brains, because in the intra when I'm doing non-drainage, the fluid is there. But as 1 or 2 days passes, the retina flattens, and then I add laser. Also for my good sleep of the next day, because cryo will take 14 days to have its major effect, versus laser will have immediately on 1 or 2 days, and maximum effect will come in a week. So I agree with Dr. Hudson that laser is a good idea.
So I think
the
take-home lesson for a resident is, I think Charles Kippen mentioned always, do the least get the retina attached for any detachment. So I think again, this is what I learned from Dr. Badrinath, who was trained by Skipens, and I have met Skipens also. He's come to the clinic in '93 in Mumbai, and so I think the one lesson to every retina fellow and resident is, I think you should learn the best from every teacher, and finally, I think you should see what is good in your hands, as Dr. Jaydeep said, in my hands. I think that's important. And that is why I actually wanted to make a presentation, which I'll probably make it in the next second or third class. The last chapter of Steve Charles' book, Surgical Self-Education, which says, first you have to equip yourself with knowledge, experience, and this is the first learning.
I want to watch this. I want to watch this lecture. This is going to be amazing. Yeah.
Yes. Yes.
Don't forget to spread the link for us.
I remember making that presentation for you, sir, in 2007 or 8, I believe.
No, that is a presentation today. Me and Aishwarya was searching. I'm searching for that presentation.
I hope I have it somewhere with me. Because
no, it is there in the cloud. Somehow I'm not able to get it. Otherwise, you have to. I thought of giving homework.
It's one of the most. Although I was still in my residency, but that chapter is, I think, the first chapter you should read before you do VR surgery.
Correct. That's what I thought. Today I'll give a talk and record it, but somehow I couldn't get the slides. Maybe we both can search it. Okay, great, Hudson. You have anything more now, or you want next week now?
No, I wanna ask Aishwarya. Aishwarya, she didn't speak much. What do you think? What did you think, Aishwarya? You are doing more buckles today, more vitrectomy.
Yeah, it was a very nice lecture, sir. Thank you so much. I was actually listening to all the points by all the teachers in this panel, and trying to understand whatever I could.
No, I think Aishwarya is actually coming to the hospital tomorrow to meet all of us, and in the meantime, she just finished her residency about 2 months back, and I think she's in the juncture. So that's how I thought this can be a thing for many fellows and residents without work now, and I'm glad you created the time. So I'm happy Aishwarya also picked up to at least listen now. I still don't find residents are all worried during this time. Fellows are worried during the COVID time in India, and they are wondering how to live and how to survive instead of learning. So I'm happy we are creating an environment for learning. I'm glad she's there. And
thank you very much, Natarajan. It's so good for me to interact with you because I had many mentors. I have many mentors, retina professors, and so I have the ideas from all of them. And then I created mine.
Yes.
And that's the thing to go. Otherwise, you would be doing the same thing. And no, I don't know what to do now. And but Natarajan said I should do this now. This is the complication that I got, and I have to get away with that by doing this technique, the other technique. So it's very good to know how people do around the world. Many different thoughts and things. And as I was saying, the laser is something we commonly do here. Some people don't do, but they still use cryo. Some people don't. You prefer to do the thing, the laser 2 days later. Maybe I prefer to do it right away, and so I would use a band or a radio band or not, or a radio element or a 277 or 42 abroad, this and that. So these things we learn, So it's an honor for me to be here, and because we are discussing these things, we also learn again. We revise, we review the things, and we discuss, and we try somewhat help you as well. And it's very good to interact with you. It's an honor for me.
Yes, sir. You want to say something?
So I had a question, sir.
Okay.
Actually, I had a case, if there's a pseudophakic inferior retinal detachment where you can not visualize the break, but as per the Linkoff's law, you think that the break should be here. So, would it be right to go with a buckle in such cases, or do a vitrectomy because you have not been able to visualize the break?
If you are not able to visualize the break, and you can go ahead and do a vitrectomy straight, because you might not have seen this break, or might be a very tiny little break. And so by doing the vitrectomy, you might do the laser in some places there, like inferior, you do some laser, just a tiny line to protect, and then you could do supratemporal, infratemporal, and supranasal, and also where the infusion line is. Otherwise, you wouldn't get the break if it was there. So you could go ahead straight with the vitrectomy, remove the vitreous, and do some laser where you thought the break could be, the position of the break. So I would do the vitrectomy straight in this case. Otherwise,
How about if it's an inferior RD with a slight fluid slightly higher up on that side, so we know that the break should be somewhere here around as per the Linkoff's rule, and then place a buckle there, and just a buckle, not a vitrectomy. I had a similar case, and I decided to do a vitrectomy or do a buckle based on assuming that the break would be where as per the Linkoff's rule, and luckily for me the case settled. But I was not sure if I did the right thing or not. Should I have gone for a vitrectomy or not? So I just wanted your opinion for the same.
Yeah, this case, if the patient was pseudophakic or phakic, then I would go straight ahead and do vitrectomy. But if he's phakic and the media is clear, and you don't actually have, you have the detachment, but you don't have the PVR, and the retina, the retina detachment is inferior, then I will go ahead and do the scleral buckle, even though I don't see the break, because after drainage, and then I would drain in the surgery. I would probably see the indentation, and then I would see the break there. But if I didn't see the break, because I know the retinal detachment is inferior, then I would do some cryo in the inferior part, even if I didn't drain. I would do some cryo, I do the buckle, and I would do the buckle first if the patient was fake. But if the patient was pseudo-fake or fake, then I would go ahead straight and do the vitrectomy.
So, Asta, I think you can, if you don't have vitrectomy option available with you, then this can work fine. If you have no option and the patient, you are the only person who knows how to do a buckle around and no vitrectomy available, you can go ahead with it. But anyways, in case you really feel like you want to do a buckle in such a scenario, then you can do a end-to-end buckle. So what is end-to-end buckle is nothing but you see the extent of the SRF in the aura, and you cover the entire area of detachment with the buckle and do cryo to that entire area. Probably while doing cryo, you might notice a break, and then you are confident.
Buckle and huge, almost like a 180 approximately.
That's what. So if you really want to be sure and you want to do buckle, otherwise where will you place when you don't know where the break is? How will you decide? So if you want to be sure, you do an end-to-end buckle, that is cover the entire area of retinal detachment at the aura, that is, and do cryo to that entire region. And in case you find a break while doing the cryo, good enough, you can decide you put the buckle there, because you do cryo before putting the buckle. So you can first do a cryo and check where the break is. If you still can't find it, then put the buckle end to end, and then cover it with obviously you will put the 240 band along with it, and check the entire periphery elsewhere also to make sure there are no other breaks. And sometimes there can be a break superiorly, which can have a tract, and inferior detachment might be there, while whereas the break is somewhere in the superior quadrant with a tract. So that is also a possibility. So look for that. And drainage,
very good ideas.
Such a case.
I wouldn't do that much cryo. I would do just some economic cryo, some cryo below, some cryo here and there. But I would do, because the cryo, after you are doing the cryo, the break might pop up, and you see in the middle of the cryo, see the break there. I've seen these images. It's interesting to see. I don't know if we have available videos on that, but Natarajan, would be great to see, cryo, and you're doing the cryo and the break popping up there. It's interesting. Actually, I have a video on cryotherapy, and I'll share with you later. I will share this with you. I have this. I have to download it down to this computer here, and I will share this video to you. It's very interesting.
So good. So I'm happy we have created some time for the residents and fellows every week. So we will see you next week, Tuesday. Right?
Thank you very much for
Yes.
interacting with me. Thank you, Ashara, Amit,
Thank you, sir. Thank you, sir.
JD,
Thank you, sir.
Professor Natarajan. Always honor to hear. And Amit.
I mean,
Only one doubt.
Thank you.
The painting behind seems to be retinal vessels or
just
something.
you're already taken over.
Dr. Hudson.
This painting.
Okay.
This is very beautiful. This is Portland, United States.
Looks like retinal vessels.
Yeah, it looks like retinal vessels. My partner that works with me, Dr. Fernando Verissimo Pacheco, it's a picture actually. He was in Portland and he makes pictures. He's a photographer as well. He's an ophthalmologist, general ophthalmologist. He does plastics and everything but retina. And this is from him. I love this. Just a moment. See, you see better now. It's shiny.
Yes. So where is Daniel today?
Okay.
Where is Daniel?
Daniel is sleeping.
Sleeping. Okay.
It's,
I just saw
because
Jaideep's
he
son
left-
was there, and Amit, you have children?
Yeah.
Amit?
My son is putting one of the microphones in his ear and listening to Dr. Hudson.
Very
Young,
good.
young
yeah.
ophthalmologist.
I was watching him. He was plugging and unplugging the thing in our ear. He's very
Jaideep sir, Dr. Jaideep is smart. He's teaching him buckle immediately.
No, actually, Jaideep. He was removing the earphone. He's
Yes.
very happy now. He was.
He's the next buckler.
And Asta has got a twins.
Say hi.
She's got a 1.5-year-old twins.
All right.
Yes. Okay. Okay. See you.
Yes, sir.
Thank you.
Thank you. Thanks a lot.
Thank you. Thank
Thank
you.
you.
Yeah.
Thank you very
Thank
much,
you, sir.
sir.
Yes. Yes.
Thank you, everyone. Thank you, Dr. Hudson. Thanks.
Pleasure is all mine. Thanks a lot.
Thank you.
Thank you. Thank you, Dr.
Bye-bye.
Hudson.
Bye, sir.
Bye.
Damn it, sir.
You.